Thank you very much, Nicola, and thank you to H3D for inviting me to discuss one of the most challenging and interesting topics that we face at the moment. I think my work comes a little bit further downstream from where a lot of you guys are working in discovery and development. So, just to contextualize my work, although I do get involved in clinical trials and had the pleasure of doing the first in human on MMV048 that was discovered by your group, most of my work focuses on policy making, as Nicola mentioned, including for South Africa, across the southern East African region, and for WHO, and increasingly also monitoring for drug resistance. I started in this field when um, we're tackling chloroquine and SP resistance, which I'm sure will tell you how very, very old I am. And I feel like my career has gone a full circle because we're now facing antimalarial resistance in a big way again in Africa. So, just as a way of introductions, a lot of what I'm going to talk about are artemisinin-based combination therapies. And these are the backbone of how we currently treat uncomplicated and severe malaria, and are likely to be treating it at least for the next 5 years. And artemisinins are used not on their own, they're very short acting, but they're used in combinations, hence the name, artemisinin-based combination therapies with longer acting drugs. So the artemisinin component brings down the parasite biomass, and then the partner drug, which is longer acting, will mop up the remaining parasites. And the reason for this explanation is that we are now tackling a major threat of artemisinin resistance. So this threatens everything that we have available for treating malaria effectively. This started in the early 2000s in Southeast Asia. Cambodia seems to be the epicenter of drug-resistant malaria. And they discovered that parasites that had artemisinin-resistant genotypes took longer to clear, but if the partner drug still worked, the combination would work. But that longer parasite clearance time has been tracked over time here. So you see from less than 24 hours in the early 2000s to the majority of parasites, 70% or more, taking more than 3 days to clear the biomass that's visible to a microscope. And so that is a problem by itself because the partner drug is then left doing the whole job on its own. And then with all that drug pressure, you end up with partner drug after partner drug after partner drug failing. And we ended up in a situation in Southeast Asia where in Cambodia, 4 ACTs were failing. We only had 5 to speak of. In Thailand, 3. In Vietnam, and there were 2 drugs failing. And yet, Southeast Asia could contain this problem because they had very few cases everywhere other than in Myanmar. And Myanmar is a bit of a black box because politically we don't get to hear what's happening there. So that was the situation in Southeast Asia that I've been watching with anxiety for almost 20 years, knowing that it's going to come to Africa sooner or later. Are we going to be ready? And when Africa has 95% of world malaria cases, when we have treatments failing here, the consequences are on a scale that's unimaginable in Southeast Asia. It was exactly the same problem with chloroquine resistance, sulfadoxine pyrimethamine resistance, started in Cambodia, spread across Southeast Asia, reached Africa, and then our treatment started failing, and there are thousands and thousands of unnecessary deaths caused by ineffective treatments. And we hope that we've learned enough in the last 20 years to tackle the situation better. So our worst fears were realized when Rwanda was the first place to report artemisinin resistance that was confirmed. That was rapidly followed by Uganda, which is now the epicenter of drug-resistant malaria in Africa. And they have 5 different validated mutations conferring resistance to the artemisinins. Tanzania and the Horn of Africa are also facing similar problems. Some places we've just confirmed that they have the mutations associated with delayed parasite clearance. Other places, they've actually confirmed that delayed parasite clearance. Why do we worry so much about it? Well, if you're dealing with a poverty-related disease, which I know you guys do a great job on, and you have very few treatment options to start with, and you have all of them dependent on the artemisinins, when things go wrong, they can go badly wrong. Firstly, I've mentioned how you get drug pressure, which facilitates partner drug resistance. So in South Africa, the only artemisinin-based combination we have is with artemether and lumefantrine. So lumefantrine is the partner drug. We also have increased transmission, partly caused by that delay in parasite clearance. Parasites have longer to form the gametocyte stage, the sexual stage that infects a new mosquito. You get reduced efficacy to the ACTs once your partner drugs fail, and then you get the spread of the resistance, and you start spinning round and round in a vicious circle. The increased gametocyte carriage, which is going to be one of the things I'll focus on, with when you have resistance, they've discovered that there's up to a 4-fold increase in gametocyte carriage, and we can assume that's more or less a 4-fold increase in malaria transmission. So we've had scattered reports of treatment failure to these artemisinin-based combinations, but it's quite complicated to confirm it, because it could be partner drug resistance combined with artemisinin resistance. It could be poor quality drug. People don't take their drugs properly. People don't get dosed properly. So WHO is, I think, a bit too reticent to say we've got a failing combination in a particular place. So in all these scattered spots, the red dots are showing you places where artemether lumefantrine is failing in more than 10% of places. And that 10% threshold is set by the WHO as the time at which you must change your artemisinin combination from, say, artemether lumefantrine to artesunate amidiaquine. You've got to change your policy before you start having too many failed treatments, too much transmission, and all those consequences. The yellow dots show where piperacin is a failing artemisinin-based combination, and there's only one green dot here that I can see where artesunate amidiaquine was shown to fail in over 10% of patients. We're going to spend a lot of this afternoon talking about Uganda, because it's the epicenter of drug resistance. And here you will see the most recent artemisinin combination therapeutic efficacy studies that were conducted 2022, 2023 in 3 sites. Each site looked at 2 different drugs. And what you will see is that if this is your 90% threshold of efficacy, 2 sites showed that artemether lumefantrine had more than 10% treatment failure rates. You may be wondering about why we have blue and orange in these graphs. So when we look at the efficacy of drugs, we don't know initially if someone has a recurrence of their malaria 3 or 4 weeks after treatment. Is it the original parasite that has survived treatment and comes back? That's called a recrudescence, and it's a PCR-corrected treatment failure. And so that's really confirmed the same parasite could not be cured. On the other hand, we can also have a new infection. There are places in Uganda where you have 1,000 infected mosquito bites per person per year. So that means you get malaria 3 times a day. So you're pretty likely to get a reinfection. And so we want to know, is it a new infection? which is shown in orange, or is it the original parasite that has exactly the same genotype, we think, coming back? And so what you will see in these two places that are of concern, where artemether-lumefantrine wasn't meeting that PCR-corrected cure rate of 90%, is that there's also an incredibly high rate of new infections occurring in just 4 weeks. And why I'm particularly highlighting this fact is that in the public sector in Uganda, which is where poor people will seek treatment, the only option they have is artemether-lumefantrine. So if you go back to the public sector, even if it's with a new infection, you're going to get artemether-lumefantrine again, and you go back again, you'll get it again. And that sure as any egg's going to guarantee you will get drug resistance sooner or later. And so that's the situation that at least 2 districts in northern Uganda are facing. And even a new drug called artesunate pyronaridine that hasn't been widely deployed, is pretty expensive, only available in the private sector. Even there, they were getting lots of new infections occurring within this follow-up period. So this is about as bad as it can get for study results. So the question is, are we just dealing with artemisinin resistance? And we know that they've got the most resistant parasites in Africa, in Uganda. They looked for artemisinin resistant mutations in 16 districts. And in 15 of the 16 districts, they had more than the 5% threshold the WHO starts worrying about, excuse me, artemisinin resistance. And in fact, in 11 of 16 districts, over 20% of their parasites were artemisinin resistant. In one place, it went up to 68%. So if that's not bad enough, we then start looking at lumefantrine resistance. And this, I know you can't read it, but it is the IC50. So the inhibitory concentration to kill 50% of the parasites increasing over time. And what you see in the last 3 years is that more and more and more of the parasites have much higher lumefantrine concentrations needed to kill the parasite. So it's no wonder whatsoever that they're starting to see artemether-lumefantrine treatment failure rates at more than the allowed threshold of 10% and very frequent reinfections. Initially, that was just seen in northern Uganda, but now it's also being seen in western Uganda. So WHO launched a strategy in 2022, October, to guide countries in Africa. How are you going to respond to this problem? And there are 4 pillars: strengthen surveillance, so you recognize you have a problem in time to do something about it. Make sure that you use your drugs in a way that is going to make them last as long as humanly possible. React to resistance to try and stop its spread, and try and stimulate research and do innovations so that we use the tools that we have to survive the next 5 years before, at least next 5 years, before novel antimalarials that don't rely on the artemisinins so much become available. So what I thought I would do with you today is just take you page by page through this strategy. Ignore the strength and surveillance because I don't think that's of particular interest to you guys, but just give you one example for each of the pillars about how better to use the medicines we currently have, how to stop the spread of resistance, and what options we've got to eke out our survival until we have new drugs available. So in terms of optimizing and regulating the use of treatments to limit drug pressure and to be proactive about it, there are a number of things that we can do, but use medicines carefully, make sure that there's a diversified availability of options, so not all the pressure is put on one drug. So lumefantrine has been by far the most widely used partner drug, partly because it was the first introduced, And the WHO had a subsidized rate, so it was sold at no profit to the manufacturer, Novartis, and it's well tolerated, became very, very widely used, and currently 15 of the 18 countries in Southern and East Africa use artemether lumefantrine as their first-line treatment. And in 5 of those countries, including South Africa, it's the only treatment option we have available. The example that I thought I would focus on, as I think it is something that relates to your drug development work, is to prevent exposure to subtherapeutic drug concentrations. A good few years ago, I spoke with H3D about one of my pet topics, which is how the people that need malaria treatment the most, very young children, pregnant women, those with comorbidities, are often excluded from the clinical trials that we use to license and make available malaria treatments. And one of the areas we've been particularly concerned about are children who are malnourished. About 1 in 3 African children is malnourished. And you can imagine that socioeconomically and geographically, the areas where you're going to get malaria are the same areas where you're going to get malnutrition. This is a study we did a few years ago looking at day 7 concentrations of lumefantrine. And we were looking at different age groups labeled along the bottom here. And we separated out children that were underweight for age in the dark gray and not underweight for age in the light. And what you will see is that particularly for very young children under the age of 3, your chances of having lower lumefantrine concentrations are much higher if you are malnourished or underweight for age, even more so if you are 1 year old, and even more so if you're an infant, a baby under 1 year of age. What we didn't know is this a problem across all children who are underweight for age, or is it something specific for acutely malnourished children or chronically malnourished children? So what we did with the Worldwide Antimalarial Resistance Network is we pulled together all the individual patient data that were available where we had a child with both a weight and a height and an age. And we could then work out their weight for height. And that was useful because you can separate out acute malnutrition and chronic malnutrition. And here in the very small print that I'm sorry that none of us can read, what we showed is that if you're an acutely malnourished young child under the age of 5, you have a higher risk of failing malaria treatment with an artemisinin combination. You have slower parasite clearance times, you have more chances of new infection, and you have a higher chance of a true failure, or what we call recrudescence. And what many of you will know is that if you are giving suboptimal drugs exposure, you are encouraging drug resistance to develop because the parasite is more likely to survive in an environment where the drug concentrations are suboptimal. So one of the things that we can do together going forward is make sure that prevalent comorbidities like acute malnutrition, like some drug interactions with TB drugs or whatever, that we dose people appropriately from the get-go so we don't get selection for resistant parasites. Let's move on to pillar 3. And we want to stop the spread of resistant parasites. And of course, you can do that by controlling mosquitoes. You can use bed nets. You can prevent malaria. You can use vaccines. You can use preventive treatment. But the one I want to focus on today is, because we're all keen on drugs, is how we use drugs to limit the risk of increased malaria transmission of resistant parasites. So people often focus on how delayed parasite clearance increases treatment failure. But I mentioned earlier how much you can increase gametocytes by having these resistance mutations. that increases transmission, you get the spread of resistance, and then that further increases treatment failure. So what can we do drug-wise about that? This is probably the simplest life cycle ever shown of a malaria parasite on an H3D webinar, for which I apologize, but I like to keep things simple. So most of the drugs that we have to treat patients act against the asexual parasite stages that make people sick. It's an obvious place to target. But some of these asexual blood stages, like humans, mature into becoming sexual stages of the parasite, also known as gametocytes, and that's what affects the next mosquito and goes on to bite the next person. So if we have drugs that can zap these gametocytes, they're not going to help anyone get better, but they are going to reduce transmission. And when we're worried about transmission of resistant parasites, then we're really, really grateful that we have a drug called primaquine that is really, really effective at reducing sexual stages, including the mature gametocytes. And that happens even if you give a single low dose of primaquine, which is really good. When someone goes to a clinic, as you give them the first dose of their ACT, whichever it is, you give them a single tablet of primaquine, and that reduces the chance of them transmitting malaria. So again, with the Worldwide Antimalarial Resistance Network, Daniel Yilma and colleagues did a really impressive individual patient data meta-analysis with almost 6,000 records searched. They ended up enrolling 35 studies, and we had almost 6,000 patients where we could look at the safety and at the efficacy of a single low dose of primaquine to reduce transmission of malaria. And this was necessary for two reasons. Firstly, the WHO recommended that a single low dose of primaquine be added to malaria treatment whenever you're trying to advance malaria elimination or whenever you're trying to tackle drug-resistant malaria. But secondly, in the coming month, will be the first time that a formulation that is suitable for use in young children, a primaquine formulation suitable for use in young children, will be submitted to WHO for pre-qualification. For 60 years, primaquine has been around, but it's been really, really difficult to dose it in young children because it's a small, hard tablet that can't be divided, difficult to crush, difficult to dissolve. So we're really looking forward to having a pediatric formulation. And so what we realized is that instead of going out trying to study the safety and efficacy of primaquine in very young children, we could just pool all the available data and show that we've already got enough data on its safety and efficacy. And one of the ways that we have as a surrogate marker of the efficacy of primaquine is to look at the prevalence of gametocytes a week after treatment and compare those who were given an ACT with primaquine with those given an ACT alone. For those who love detail, you can see the forest plots on the left, but for most people, it puts people to sleep. And so over here, it's a much simpler way of showing what the efficacy is. And what it shows is if you have 1,000 patients, you will end up with 318 fewer patients carrying gametocytes if you give the ACT with primaquine than if you give the ACT alone, which is a pretty impressive efficacy rate. An incidental discovery from this really large analysis, which I think is also important when you're thinking about drug development, is that all ACTs are not the same. So if you look at the probabilities of gametocytes 2 weeks after treatment, and you compare artemether-lumefantrine with primaquine, or dihydroartemisinin and piperacin, a different ACT, with primaquine, you will see that you've got, if you were treated with DP, you're much more likely to carry gametocytes unless you're getting the WHO recommended dose of primaquine. So when most ACTs are used without primaquine, we know that DP is going to be at much greater risk of spreading resistance unless it gets given with primaquine. So particularly in the case of DP, we should really make sure that all our patients get given primaquine at the same time. At a time of spreading drug resistance, you really don't want all these extra gametocytes running around. And if you're doubtful about surrogate indicators, these results were confirmed when they do what they call membrane feeding experiments, where human blood infected with parasites gets exposed to mosquitoes, and then they look at how many of those mosquitoes get infected, and they confirmed a significant difference between the DP and the artemether-lumefantrine. So that's the story for pillar 3 about using single low-dose primaquine to stop the transmission of resistance parasites. And the reason why I thought this was good to mention in a group involved with drug development is that if you were just focusing on the endpoint of curing patients, which is of course great and saves lives, if you can do it and at the same time get rid of gametocytes, you've got a much better drug. It's a drug that's going to last much longer because you'll have a lower chance of resistance spreading if you happen to get resistance developing in that parasite. The last pillar we're going to look at today is what we can do and innovative approaches with currently available drugs. As I've mentioned a few times, the drug development pipeline is healthier than it's been before, thanks to people like yourselves, but we do not have anything likely to become licensed or even a dossier submitted before at least 2027. So we've got a good few years ahead of us, which countries like Uganda cannot afford unless we can find innovative approaches to use the currently available drugs better. So this is a bit busy, so I've broken it down into a few steps. So let's say you're in charge of malaria control in Uganda. You know your artemether-lumefantrine is failing. What options do you have? So the one point to make is that artemether-lumefantrine is not failing totally, but it definitely needs quite a lot of help. Some people suggest a longer course, because if you have a longer course, you will have your lumefantrine concentrations sustained for longer. So parasite clearance is a little bit delayed because you've got artemisinin resistance, then you've got longer to mop up the remaining parasites. But of course, on the downside, you're going to have problems with adherence. People who are used to feeling better after 3 days are not all likely to finish a treatment course. And of course, when it's a poverty-related diseases, people will often try and save medicines for the next time they're sick or their child is sick. Single low-dose primaquine, I hope I've sung its praises enough, won't go there more. You can say, well, if my artemisinin is only working partially because I've got delayed parasite clearance and lumefantrine is not doing a good job, why don't I go to some of the other drugs available? So dihydroartemisinin and piperacin, DP I've mentioned, artesunate pyronaridine I've mentioned, artesunate amidiaquin are the 3 widely available options in Africa. So those could be considered. Or you could consider going from having 1 drug available in the public sector in Uganda to having 2 drugs available or more drugs available, and that's called multiple first-line treatment. Or you could go combining. So your artemether-lumefantrine could be combined with amidiaquin. Or lastly, your ganaplacide, which is this new drug that we hope will be soon replacing artemisinins, works even more rapidly than the artemisinins. And this combination has recently gone into phase 3 clinical trials. But a fixed dose combination of artemether-lumefantrine or ganaplacide lumefantrine is only likely to be available from 2028. So you could be doing it with loose tablets of artemether, lumefantrine, and amidiaquine earlier, or you can have to look at one of these other options. But if you need a short-term solution, your options are not many. One of the things that's greatly to our advantage, I think, when we consider replacing artemether lumefantrine with artesunate amidiaquine, is that there's an inverse mechanism of resistance to amidiaquine and to lumefantrine. So if you get drug pressure exerted, ignore drug pressure for a moment. If you have this particular genotype, then your lumefantrine is going to work better. If you have this particular genotype, then your amidiaquine is going to work better. So what happens when you have a lot of lumefantrine drug pressure, which is what we've had in Africa since 2000? 85% of ACTs sold in Africa are artemether lumefantrine. Then you're going to end up annihilating the genotype that is killed by lumefantrine, and you're going to end up having more and more of the genotype that is resistant or less sensitive to lumefantrine, but is more sensitive to amidiaquine. So that would make a very easy choice. If I was in Uganda, I would start using amidiaquine there tomorrow, because that's going to be the most effective treatment option, at least in the short term, because we know that the drug pressure has pushed parasites towards being amidiaquine sensitive types of parasites. What about dihydroartemisinin and piperacin? Well, I've already mentioned that I'm a bit worried about this combination in terms of its high chance of carrying gametocytes. And this was confirmed in Southeast Asia, where on the western border of Cambodia, we first got the artemisinin-resistant parasites, and somehow they then made friends with the piperacin-resistant parasite, and that combination with mutations favoring both artemisinin and piperacin resistance then swept wildly across into Thailand, into Laos, into Vietnam, and became the dominant genotype. And that happened in a couple of years. Then the last currently available option is called artesunate pyronaridine. It's the newest kid on the block. It was only recommended, I think, by the WHO in the late 2000s. The downside is it's the most expensive option that we have. And even when you have the Global Fund buy bulk and save prices, it's by far the most expensive option. So when I had a call yesterday with the head of the malaria program in Uganda, one of the things that he said is, well, if he chooses that option, instead of being able to treat 20 million patients, those are the numbers he works at, which terrify me, he'll only be able to treat 10 million or less patients. So those are things that need to be considered, as well as safety and tolerability. Then we have the last option that I'm going to mention is multiple first-line treatments. And you can either do that at the individual level or at a community level. And what we're trying to do here is make it as hard as possible for a resistant parasite to survive. So if you are artemether and lumefantrine resistant, then you need to have that parasite exposed to another drug to which it's not resistant. And if you've got enough diversity within a community, then within a relatively short period of time, parasites will be exposed to different people, different drugs, and hopefully one or more of them will kill the parasite. The particularly good combination, for the reasons I tried to explain with different genotypes conferring inverse resistance patterns, would be if you combined your lumefantrine and amidiaquine. So you add amidiaquine that's still available as loose tablets to artemether lumefantrine, or you create a triple combination, then you're pretty guaranteed to be able to kill those parasites. We haven't got very much clinical evidence. For policymakers, it's a bit hard when there's not a lot of evidence available, but they have done a clinical trial in Cambodia and Vietnam. And we know that Western Cambodia is the most resistant area in the world. And here, when you use the artemether lumefantrine on its own, cure rate is less than the required 90%. But if you combine it with amidiaquin, then it achieves the desired concentration. Same seen, significant improvements in Vietnam. So this is starting to show that even in an area with a lot of drug resistance, you end up with an effective treatment when the odds are pretty much a bit against you. You'll remember that I said early on that in Cambodia at one time, there were 4 artemisinin combinations that were all failing at the same time. The only other evidence that we have for multiple first-line treatment are based on mathematical models. I was in Geneva last week where WHO convened a meeting about multiple first-line treatments. And these mathematical models were trying to project how many treatment failures you would get over the next 5 years if you looked at all sorts of different options. And what you'll see is that if you were to just change to DP, with all the disadvantages that I've mentioned, you will end up with the most treatment failures. But if you combined artemether lumefantrine with amidiaquin, that would be one of the options that you could have to have the fewest treatment failures. And there are lots of different options looked at in between when you're having 2 different drugs available at the same time, used in different ratios. But those are the clear take-home message. The last point that I want to make, because I think a lot of you think of drug development as a process that goes on until your medicine is licensed. And for people dependent on the public sector, poverty-related disease like malaria, it's sadly not that quick. So even if we were to get a new drug licensed in 2027, it then gets submitted for WHO pre-qualification, which is the condition for which the Global Fund for Fighting AIDS, TB, and Malaria that funds most of the antimalarial drugs available at the moment. They want to know about good quality of the product, so it has to be WHO pre-qualified. That can take a year. And if you then have to wait before you get into WHO or national treatment guidelines, it can be another year. And these people are looking at all sorts of things, not just efficacy and safety and drug quality, but the level of your evidence. Have you studied the people that they're interested in? Have you considered acceptability, equity, and all sorts of things? So I think that more can be done in the earlier phases of drug development to speed up these last 2 steps. And what I was really pleased to hear last week in Geneva is that the WHO Global Malaria Program has made a commitment that anything going in from next month, so the pediatric primaquine formulation, the process of pre-qualification and getting into WHO guidelines can be reviewed in parallel, and both should be completed in under 12 months because they understand how desperately we need these new drugs. And those developing these drugs need to try and put their put their thoughts in the minds of people trying to make these decisions. Is how much evidence do you have in 1 in 3 malnourished children, for instance? So in conclusion, it's important to highlight how much we rely on the artemisinins at the moment as the backbone for treating not only uncomplicated malaria, but also severe malaria. We have unequivocal evidence of artemisinin, what WHO calls partial resistance, not just in Southeast Asia, but in East Africa and the Horn of Africa. And we're starting to see the efficacy of lumefantrine waning, although this is not officially confirmed. Novel drugs are only likely to be available in 2028. And more worryingly for me, both of those drugs that are likely to be available soonest depend on lumefantrine. So if we don't protect lumefantrine for the next 4 years, we might not have effective novel drugs in 2028. We need to make sure that we use drugs wisely. Drugs are not used at the right dose. Often courses are not completed. Often drug quality is poor. And if we don't get rid of those bad habits, then even a new wonder drug that we get in 2028 is not going to last for as long as it needs to. And all of your work is desperately needed because, as you can see, we need novel antimalarials. I'd like to end by acknowledging the many, many people that made this work possible. Thank you, and over to you for questions.